Welcome to the third video in the series Arterial Blood Gas Analysis or ABG Analysis. If you would recall from the previous video, we discussed that if there is a change in the carbon dioxide levels, like an increased carbon dioxide, the renal system compensates by increasing the bicarbonate levels and thus returning the pH back to normal. And if there is a metabolic abnormality increase in the bicarbonate, the respiratory system increases the carbon dioxide and thus again normalizing the pH. Now, while this looks elegant, this is rarely true in a clinical setting. Compensation happens in a predictable manner and rarely achieves a normal pH. Let us explain. Let us take metabolic acidosis to explain the point. Metabolic acidosis, if you remember, is a low pH and a low bicarbonate. The compensatory change would be, again, if you would recall, it would be a reduced carbon dioxide levels. But how much is compensated? For every 1 milliequivalents per liter fall in the bicarbonate level, there is a fall of 1.2 millimeters of mercury of PCO2. Let us look at an example. I will leave the predicted values at the bottom of your page for your reference. The pH in this example is 7.16 and the bicarbonate is 14. So if you would recall from the first video, step 1 is to determine whether this is an acidosis or an alkalosis. So the pH is low, so this is an acidosis. Step 2, is it a metabolic or a respiratory acidosis? So here the bicarbonate levels are low, so this is a metabolic acidosis. So we said for every 1 milliequivalents per liter fall in bicarbonate, there is a 1.2 millimeters of mercury fall in PCO2. So the compensatory change would be reduced PCO2. But how much PCO2 would be reduced? Again, for every 1 milliequivalents per liter fall in bicarbonate, there will be a 1.2 millimeters of mercury fall in PCO2. So how much has the bicarbonate fallen by? The normal bicarbonate level is 24 and the bicarbonate level here is 14. So that is a fall by 10 milliequivalents per liter. So how much will the carbon dioxide fall by? That is 10 into 1.2, that is 12. So the expected PCO2 will be 40 minus 12, which is 28. So the ABG will look like this if there is the expected compensation. So the pH will be 7.16, bicarbonate will be 14, and PCO2 will be 28. For metabolic alkalosis, the primary change is increased bicarbonate levels and the compensatory change would be increased CO2. For every 1 increase in bicarbonate, there would be an increase of 0.7 units of carbon dioxide. Let us work through an example. The pH here is 7.58 and the bicarbonate is 32. So this is clearly a metabolic alkalosis. The bicarbonate here has increased by 8 units. So the PCO2 will increase by 8 into 0.7, which is 5.6 units. So the expected PCO2 will be 45.6. So the ABG here will look like this provided the compensation has occurred. The pH would be 7.58 and the bicarbonate 32 and the PCO2 will be 45.6. For metabolic abnormalities, the compensation is by the respiratory system. The respiratory compensation happens in a matter of tens of minutes. In a clinical scenario, the compensation has usually occurred by the time the patient presents to the ER. For respiratory abnormalities, the compensation is renal. Renal compensation tends to take 2 to 3 days for completion of the compensation. But there is a small acute change in the compensatory direction due to changes in the bicarbonate buffer. Respiratory acidosis, the primary change is increased PCO2. The compensatory change is bicarbonate level increase. For every 10 increase in PCO2, there is a 1 increase in bicarbonate in the acute setting and 4 increase in bicarbonate in the chronic setting. Remember, these are approximate values, but these are sufficient for a clinical scenario. In a respiratory alkalosis, the primary change is reduced PCO2 and the compensatory change is reduced bicarbonate. For every 10 decrease in PCO2, there is a 2 decrease in bicarbonate in the acute setting and 4 decrease in bicarbonate in the chronic setting. So let's summarize the expected compensation levels again. Now this chart may look daunting, and I'm not going to lie to you, it is daunting initially, but it is very important to have an idea or to memorize these numbers for your clinical tasks. Let's go through the chart again. This is something we can all agree on. For acidotic changes, the pH falls, and for alkalotic changes, the pH rises. For metabolic acidosis, the primary change would be reduction in bicarbonate levels, and the compensation would be reduction in carbon dioxide. The carbon dioxide reduced by 1.2 for every 1 fall in bicarbonate. In metabolic alkalosis, the primary change is increased bicarbonate. The compensatory change is increased carbon dioxide. The expected compensation is 0.7 increase of carbon dioxide for every 1 increase in bicarbonate. In respiratory acidosis, the primary change is increased PCO2. The compensatory change is increased bicarbonate. In the acute setting, the increase is 1 increase in bicarbonate for every 10 increase in PCO2, and in the chronic setting, there is a 4 increase in bicarbonate for every 10 increase in PCO2. In respiratory alkalosis, the primary change is reduction in PCO2. The compensation is reduction in bicarbonate. In the acute setting, there is a reduction of 2 units of bicarbonate for every 10 decrease in PCO2, and in the chronic setting, there is a 4 fall of bicarbonate for every 10 fall of PCO2. So to summarize, metabolic acidosis 1.2 for every 1. Metabolic alkalosis 0.7 for every 1. For respiratory acidosis and alkalosis, please recall 1, 4 and 2, 4 for acute and chronic changes, acidosis, alkalosis. So please remember these numbers 1.2, 0.7, 1, 4 and 2, 4. I'll help you understand this better by looking at a few examples. So the pH here is 7.24, the PCO2 is 70, the bicarbonate is 36. So step 1, is this acidosis or alkalosis, or is the pH normal? So clearly this is an acidosis. Step 2, is it a respiratory acidosis or a metabolic acidosis? You should be able to determine that this is a respiratory acidosis. Now, what is the compensation here? The compensation would be increased bicarbonate levels, but how much would the bicarbonates increase? So the expected compensation is in an acute setting 1 for every 10 and in a chronic setting 4 for every 10 change in PCO2. Again, the expected compensation is increased bicarbonate levels. So how much has the carbon dioxide increased by? The normal PCO2, if you would recall, is 40 and in this example is 70. So the increase in PCO2 is 30 millimeters of mercury. So the expected bicarbonate in the acute setting would be 27, that is for every 10, 1 increase. So here 30 has increased, so the bicarbonate will increase by 3. And in a chronic setting would be 36, that is for every 10, 4 increase. So here the PCO2 has increased by 30, so the bicarbonate will increase by 12. So this is a chronic respiratory acidosis because the bicarbonate level of 36 fits in our picture of chronic compensation. Let's try another example. The pH here is 7.32, the PCO2 is 30.4 and bicarbonate is 16. Step 1. Is it an acidosis or an alkalosis? Clearly, this is an acidosis. Step 2. Is it a metabolic abnormality or a respiratory abnormality? You can notice here that the bicarbonate level has reduced, so this is clearly a metabolic acidosis. Step 3. Let us look at the compensation. So the primary abnormality here is fall in bicarbonate, and the expected compensation is fall in the PCO2. How much has the bicarbonate fallen by? The bicarbonate has fallen by 8 units. So the expected PCO2 decrease is 1.2 for every 8, that is 9.6. So this is a metabolic acidosis with the expected compensation. So far we have discussed single abnormalities, that is a metabolic acidosis or a metabolic alkalosis or a respiratory acidosis or a respiratory alkalosis. But in clinical settings, patients usually come with multiple abnormalities. We will look at how to approach these cases, but we will clarify it with the help of a few examples. Let us look at a real-life example. A 60-year-old gentleman came to the ER with fever and cough. The ER doctor diagnosed as pneumonia with sepsis. The ABG is as follows: pH of 7.2, PCO2 of 16, and bicarbonate of 14. So step 1, is this an acidosis or an alkalosis? Clearly, this is an acidosis. Step 2, is it a metabolic abnormality or a respiratory abnormality? Clearly, again, this is a metabolic abnormality. So this is a metabolic acidosis. Step 3, let us look at the compensation. What is the expected compensation here? The expected compensation is reduction in the PCO2. How much will the PCO2 reduce by? We said the bicarbonate here has reduced by 10 units, that is 24 to 14. So the PCO2 will reduce by 1.2 times 10, that is 12. So the expected PCO2 will be 40 minus 12, which is 28. So the expected PCO2 here is 28. But what has happened here? The PCO2 here is 16. So the metabolic acidosis is not the only problem in this patient, because if the metabolic acidosis were the only problem, the PCO2 here would be 28. The patient has a second abnormality which has reduced the PCO2 from 28 to 16. An anomaly causing reduced PCO2 is called a respiratory alkalosis. So this patient has a metabolic acidosis plus a respiratory alkalosis. He has a metabolic acidosis because of his sepsis, and he has a respiratory alkalosis because of his pneumonia. So to summarize the concept, if the measured compensation is drastically different from the expected compensation, there is likely a second abnormality. Let us look at a few real-life examples. A 24-year-old lady was brought to the ER with ingestion of an unknown substance. The ABG was as follows. The pH is 7.18, the PCO2 30, and the bicarbonate 16. So step 1, is this an acidosis or an alkalosis? This is clearly an acidosis. Step 2, is it a metabolic abnormality or a respiratory abnormality? Clearly, this is a metabolic abnormality. Step 3, let us look at the compensation. What is the expected compensation here? It is a reduced PCO2. How much will the PCO2 reduce by? For every unit fall in the bicarbonate, there will be a 1.2 unit fall in the PCO2. Here the bicarbonate has fallen by 8 units, so the reduction in the PCO2 would be expected to be 8 into 1.2, that is 9.6 units fall in the PCO2. So the expected PCO2 would be 30.4. Now the measured PCO2 here is 30, which is in the same ballpark as your 30.4. So here there is a metabolic acidosis with the expected compensation and no second abnormality. Let us look at another example. A 24-year-old lady was found unconscious at home by paramedics and was suspected to have ingested formic acid. The paramedics reported she was barely breathing when she was found. She was intubated and an ABG was drawn. The ABG showed pH of 7.01, PCO2 of 38, and bicarbonate of 16. So step 1 here is this is clearly an acidosis. Step 2, it is a metabolic acidosis. Step 3, let us look at the compensation. We expect a reduced PCO2. The expected PCO2 would be 30. I have used the same numbers as the previous example, that is HCO316, to make the calculations easier. So as in the previous example, the expected PCO2 would be 30, but the measured PCO2 here is 38. The metabolic acidosis alone would have brought the PCO2 down to 30. But there is a second anomaly which has increased the PCO2 from 30 to 38. This second anomaly, which has increased the PCO2 from 30 to 38, is a respiratory acidosis. So this patient has a metabolic acidosis plus a respiratory acidosis. In this clinical context, the metabolic acidosis is due to the formic acid ingestion, and the respiratory acidosis is due to the reduced ventilation. If you would recall, the paramedics reported that the patient was barely breathing. So this would explain the respiratory acidosis in this case. So again, this patient has a metabolic acidosis plus a respiratory acidosis. Let us look at another example. A 74-year-old gentleman presented to the ER. He complained of vomiting for the past 3 days. He is a known case of COPD on home oxygen and has a history of chronic respiratory failure. The ER doctor ordered an ABG. The pH was 7.35, the PCO2 60, and the bicarbonate 40. So step 1. Even though the pH is on the normal range, it is towards the acidic side. Step 2. The acidity here is caused by the respiratory component because the PCO2 here is increased. Step 3, the compensation. The expected compensation in a respiratory acidosis would be increased bicarbonate. Now we know that this patient has a chronic respiratory problem, so the expected increase in bicarbonate would be calculated using the expected range for chronic respiratory acidosis. If you would recall, we said for every 10 increase in PCO2 in a chronic setting, there would be 4 units increase in bicarbonate. So here the PCO2 has increased to 60, that is an increase of 20 millimeters of mercury. So there would be an increase in bicarbonate by 8 units. So the expected bicarbonate level would be 24 plus 8, that is 32 units. But here the bicarbonate level is 40. The measured bicarbonate is 40. So there is a second abnormality in this patient which has increased the bicarbonate level from 32 to 40. An anomaly increasing the bicarbonate is known as, if you would recall from the first video, that is a metabolic alkalosis. So this patient has a chronic respiratory acidosis plus a metabolic alkalosis. In this clinical context, the respiratory acidosis is due to the COPD and the metabolic alkalosis is due to the vomiting. Let us look at another example. A 50-year-old man presented with known amyotrophic lateral sclerosis presented in sepsis of undetermined focus. The ER doctor ordered an ABG. The pH was 6.98, the PCO2 60 and the bicarbonate 26. Step 1, this is an acidosis. Step 2, it is a respiratory acidosis. Step 3, compensation. The expected compensation would be an increase in the bicarbonate levels. The expected bicarbonate level here would be 32. For ease of calculation, I have given the same numbers as the previous example, that is the PCO2 of 60. Here it is a chronic respiratory failure because of his neurological condition. So even though the expected bicarbonate here is 32, the measured bicarbonate here is 26. So if the chronic respiratory failure were his only problem, the bicarbonate level would have been 32. But there is a second abnormality here that has reduced the bicarbonate from the expected 32 to the measured 26. So if you would recall, a fall in bicarbonate is a metabolic acidosis. So this patient has both a chronic respiratory acidosis and a metabolic acidosis. In this clinical setting, the respiratory acidosis is because of his neurological condition and his metabolic acidosis is because of his sepsis. Let us stop for now. I know this video may be confusing to a lot of you, especially if you are new to ABG interpretation. Please watch the video again and try to pause in the middle of examples to calculate the expected compensation values by yourself. We will deal with more complex examples in a later video. The next video will focus on anion gap, especially in metabolic acidosis. Thank you for watching the video. Please don't forget to like, share and subscribe. Thank you. See you in the next video.